All right, so today we're going to cover massage. I will say I changed the order around a little bit, so I know how much Rosa likes me when I do that. I did change some of the slides around. So all of the content's the same, just the order of them is a little different. The reason for that is when I originally put this together, putting it together, I think I did it in the order that the textbook has it, but in practice, we want less lubrication on or no lubrication on some of the techniques, and then we want lubrication on others. And the order that we have this in starts with lubrication and then ends with no lubrication, which in practice that doesn't work for us because now our hands are all they have too much glide to it. So I switched the order around for that reason. So I have a love-hate relationship with massage, like all modalities. Patients love it, I hate it. So I think there's a couple of important things to consider for this. One of the reasons I hate it is because what do my patients want to do? They want to, yeah, nothing, right? So they want to come in, they want to lay down and say, "Oh, just make me feel better," right? And I think there's a world where that's really beneficial. I think good massage therapists make a decent chunk of money. But that's also not our goal, right? What is our goal? Our goal, we have 3 goals in physical therapy. I don't think I talk about them enough with you guys. You know what those, broadly speaking, those 3 goals are? Return to prior level of function is most likely our most common goal. Whatever you were before this injury or accident, we want to get you back there. What are some others? Next. Avoid complications down the line. Yep, minimize complications. Yep, and did you have something else? Improve current level of function. Those are our 3 things we're trying to do, right? So we can try to overthink it as much as we want, but those are our 3 goals. Improve current level of function, hopefully return to prior level of function, or for some people that won't, some people in some conditions that won't happen. And then minimize complications down the road. Where does massage? Yeah, that's exactly it. Potentially current level of function, potentially, but really in a narrow view, right? So I think massage is fantastic. I think the people that want to go get a massage, hey, I want to feel nice, great, go feel nice, right? But I'm skeptical on a lot of massage improving function. That's really where I'm limited in. So the reasons why we would choose massage is for the physical therapy benefit, right? That is our goal. It's not just to feel nice. So we have to be really careful on when we apply it because our patients will never say, you know what, I'm sick of this massage. Let's get up and do a bunch of squats, please. Okay. No, that's never going to happen. So we have to be careful. We have to really communicate well why we're doing a massage, what are the reasons for it, and really make sure that they understand it's an aspect of treatment and not the whole treatment. So hopefully we can educate our patients about that. So there we go. There's so massage the use of clinicians' hands to purposely manipulate patients' soft tissues, promote healing and restore function. All right, that sounds good. So again, it's our application, our selection of techniques and application and execution of those techniques is what we need to figure out, not necessarily, hey, this is just going to feel good. Origin massage began before recorded history and can be found in every culture of the world. Different takes on different techniques. Pretty fascinating if you wanted to look at the history and look at the cultural impacts of that as well. First up for us, our physical appearance has to be on point. So one, short fingernails, really tough to do a lot of massage techniques with longer fingernails. We don't want those digging into our patients. Odor-free hands. Removal of rings, watches, bracelets, other jewelry, long hair secured. And our scents need to be kept to a minimum. I think that should be any of this different from any other physical therapy presentation, basically the general rules, right? Environment, firm treatments tables, gather necessary equipment ahead of time, especially draping. Draping is going to be something that we really have to consider now. I can move clothing around to examine the skin before I apply a shoulder hot pack. But for massage, we're going to be asking our patients to be in as little clothing as possible. So proper draping equipment. I always say go more. If I think I need 2 sheets, I'm going to have 3 or 4 in there just to be sure. Considering the patient position is important, supine. We have to consider the goal of the treatment, patient comfort, supine, prone, side lying, seated. I don't think I have a picture of seated, but I think that can be important for us. I would guess prone is our number 1 position we'll be in, and probably the position we'll be in the most today, but always be willing to adjust your positioning based on the patient and your mechanics. So our patient comfort's important, not more important than your mechanics. So, we want to maintain our upright posture, just like if we're folding silverware at the restaurant. We have a nice wide base support so we can be nice and upright. Always make sure that our body mechanics is appropriate. And I know you guys have been dealing with this all semester long when some of the tables are dropped down way low. It looks like yours were today. If as you're working with your patient over the next couple of days with your classmates, get the table to your height. Take that extra 5 minutes to get to your height. We do have one high-low table. We don't have tremendous height differences, but we do have the high-low tables in the back where the traction is too, if we had to. So make sure, your body mechanics are important, especially when we're as students as well as clinicians. Both feet remain in contact with the floor, bend with the knees, avoid twisting, maintain neutral joints. Avoid hyperextension of wrists and fingers. That for me is the hardest thing. I have really flexible fingers. So for me, I have to be very careful with how I use my hands for my patients, not only for massage techniques, but other hands-on techniques I have with my patients. So how many here know that they have really flexible fingers and hands? And so we're going to have to really make sure that you reinforce those. I'll show you a couple of techniques when it's time for that. But it can be, it is really important for that because those notes aren't going to get typed at the end of the day if I get beat up for massaging somebody. You get paid to type up your notes. You don't get paid to actually treat your patients. Weight shifting more important to apply pressure versus just increasing muscle force. So we did this a lot with our manual muscle testing, right? I mean, that was something we always said. We're not supposed to be, using our muscle force to test their manual muscle test. We're supposed to be using our body weight and our positioning. Same thing as we're applying our hands-on technique. It's our body weight that's providing the force, not our just pure strength. So the big thing that we've got, the skill that we need to continue to develop and also use what you've already developed is our palpation ability, the perception of touch, that sense of touch. Ultimate goal is to identify the local areas of dysfunction, and then also if we can identify the area of dysfunction, we can also treat it with different techniques. Some people are going to have really be heavy-handed. We're going to need to be good classmates to say like, well, you got to back off there. And other people are going to be really way too light, and we're going to have to cue our clinicians to be a little bit more firm. And all of that is going to get better and better as our palpation skills improve. Did you guys feel a big difference improvement when you're taking kinesiology in your ability to palpate? Right. So, I mean, hopefully with that class, you were able to palpate, hey, I know this is the rhomboids because I can feel the direction of their fibers. I know it's not mid-trap because I can feel those striations and I know what the alignment is, right? So hopefully you got to that level at some point. And if you did get there, these kind of treatments are going to bring, are you saying no, you didn't get there? So it will improve. Your ability to palpate and to actually feel what that body is giving you is going to improve. It was really clunky with our manual muscle test initially, right? Manual muscle tests were trying to guess a 0 to 5, and even with that level of force, man, sometimes it was really tough to figure out, is that a 3+ or even a 4+? Like there's big range, big difference there. So it will continue to improve, and the more you do this type of work, massage or any type of manual hands-on treatment, it's all that developing our sense of touch. If we were to bring in a bunch of books written in Braille, do you think we'd be able to read it? No. But if we had a bunch of, do you think even reading a book with Braille, do you think you'd say like, oh, this has 3 dots, this one has 2? Do you think you'd even get that close? Some yes, some no, right? So, but with practice, what do you think? Heck yeah, we'd be able to do that. So that's all this. We just need more and more experience. And if you know this is a weakness of yours, when you are on clinicals, your patients will love you, and your CIs, well, your patients will love you if you just say, hey, could I have 5 minutes to just practice my massage techniques? Man, your patients are going to say, yeah, I love this student. Yeah, have them work with me all the time. As a clinical instructor, I would say, oh God, we're going down the massage route. Like you're going to make them, we got to discharge them before your clinical is up because I'm not doing this for them. So you do have to be careful. Always talk to your CI first, but anything that you want to practice, your patients are there for you to practice on. Always talk to your CI first because we don't want to get our patients hooked on some of this stuff. And I say, no, let's do a bunch of squats. No, the student just wanted to massage me, so we don't want to do that. Our hands are tools to inform us about the patient. Tightness, tenderness, adhesions, muscle guarding, trigger points, tissue density. Is the problem in these muscle fibers, are they the more superficial fibers or the deeper fibers? We sort of talked about that this semester. Just as we decide, do we want to do a superficial HOPEC or an ultrasound based on tissue depth? Well, how do we know if that quad is more the superficial fibers that are the problem or the deeper ones? Well, our ability to palpate is a big tool for us to determine that. Practice patience and concentration. Sometimes having our eyes closed can help us really try to focus in on that palpation and having our hands guide us with the information rather than just staring at our patient and guessing. Hands should be relaxed with a soft touch. Again, some of us in here are going to be heavy-handed. We're just going to need to continue to talk about that. So some of the effects of massage: increased metabolism, potentially increased healing, muscle relaxation, definitely improved lymphatic function. Really have to be careful though, because our lymphatic system is really delicate and does not take a lot of force to just collapse those lymph vessels. So when that is the goal, we want to be extremely light. We'll talk about that later on. Increased immunity, I'm not sure about that. I'm scratching my head on that one. All right, it's in the textbook. Potentially, yeah, potentially. It's one of those things that's in the textbook and you go, oh, I don't know about that. But hey, it's in the textbook. Somebody believes it. Prevents and relieves muscle cramps and spasms, definitely improve blood and lymph circulation. Here's the other thing I should say about massage that you probably already know. I am a really rigid mechanical thinker, right? I mean, that's been obvious at this point, right? That's why I like traction. I know, I can see it, I can feel it, I can calculate the poundage, it's concrete. There's a lot of effects of massage and a lot of purposes for it that are beyond my concrete level of thinking. And my job is to be open to those ideas and not completely dismiss them. I think that's something I did early in my career that I regret doing. But it's okay to be skeptical. But what do we do with all of our treatments? Every single patient, we make a good clinical judgment on how to make them better, and then we measure for progress. And if they're not progressing, we switch something. So, again, I'm skeptical on increased immunity, but hey, you know what? As much as I know, it's hard for me to admit, but I don't know everything. So potentially. Enhanced tissue repair breaks up adhesions, promotes joint function, optimal range of motion, proximal skeletal alignment, pain management. It's a non-painful touch. There's a huge. We talked about placebo a lot, right? Our patients, the power of most of our modalities and the power of placebo. There is a huge placebo effect when somebody places their hands on somebody. I don't care what the technique we're talking about, joint mobilizations, 1,000 different types of massage. There is a huge placebo effect of somebody else's hands on you trying to make it work better and it less painful. So that is really powerful. Improve blood circulation as well. Reduce blood pressure and heart rate, increase mental clarity, reduce anxiety and stress, promotes feelings of general well-being. So plenty of positive effects, that's for sure. Contraindications, acute condition requiring emergency care. Well, that's nice. That's silly. Like, 911 or Petrosage? I don't know. Let's try Petrosage. No, that's not it. Fever, sign for inflammation or infection. Acute inflammation, skin conditions, especially if there's a risk of them being contagious, we want to protect ourselves. Blood poisoning infections, malignancy, bleeding and bruising, recent surgery, burns, recent fractures, decreased sensation, increased sensitivity to touch. That's an interesting one because increased sensitivity to touch, some of our patients are going to have that, especially after surgeries. There is a treatment approach to increase sensitivity of touch. Just start with a really as tolerable of a substance as they can take, silk or something really, really soft, and then progressing our way into more and more abrasive type of touch. So again, that's a precaution. Precaution means what? Stop and think about it, right? Stop and think about it. Do you really need to do this, right? And so for some people, that increased sensitivity to touch would be really good for some of these techniques, but we have to be aware of our patient and get them on board with the treatment plan. Different cardiovascular disorders, edema, osteoporosis. Something that's not on our contraindications or precautions from the textbook that I think should be there is what? Pregnancy. Yeah, pregnancy. Yeah. So there is, but there is additional considerations for that. So while it does exist, it's definitely something that we should at least be in our precautions. Stop and think about it. Especially what was the modality that said we can't do it to the medial ankle because that's an acupressure point to stimulate contraction. I don't think it was ultrasound. Was it E-stim? Yeah. Yeah. All right. So yeah, if we can't do TENS to the medial ankle, I don't know about massage. I don't know about it. I don't know. Anyway, so here's some techniques that we're going to be learning. Some classic massage. We've got, I think there are 3 different techniques within each of these subcategories: effleurage, petrissage, and Pullman, scar massage, trigger point deactivation, myofascial release, and transverse friction massage. I did switch up the order of this. So our first thing we'll talk about and practice, transverse friction massage. So breaks up fascial adhesions. softens scar tissue, causes mild therapeutic inflammation. Why would we want to start inflammation? So much of our semester has talked about stopping the inflammation cycle. Why would we want to start it? Perfect. Couldn't have said it better myself. Eventually, if we kickstart this inflammation cycle, well, there's a bunch of good stuff that happens with that inflammation cycle, right? All the different types of white blood cells, increased blood flow. There's a lot of good that happens with it as well. When it gets to be too much, then that can cause some negative effects too. But yeah, sometimes we want to create that. When an adhesion is located within a muscle or tendon, stresses are not equally distributed through the tissues, and they tend to build up around the adhesion, causing more and more pain. So if we think back to our anatomy, these muscle fibers, I mean, that's exactly what they are, fibers, and they should be free from one another, right? So an adhesion is when there's several fibers kind of glued down to one another. So if they can't glide over one another, that's going to cause an imbalance of forces as that muscle contracts or lengthens, and that constant tugging on that restricted area is going to be the thing that causes pain. So we've got to free that area up. So when my patient asks about massage, I always say yes, because I'm a nice, kind guy, right? And then I give them a transverse fixed massage and they never ask about it again. So we'll practice this. That's why I put it first today. I was like, that's my favorite one. Special place in my heart. What's that? So there is instrument aided massage techniques we'll talk about later on. The brand's name kind of is called Graston Techniques. We'll talk about that in a little bit too. But yes, that's exactly what would be used for. Yep. Hold on one second. Give me 1 second, Jonathan. What were you saying, Robert? Yeah, so what Robert was saying was these tools can be used for exactly what we're talking about, breaking up adhesions, stainless steel tools. Yep, instrument aided soft tissue mobilization, also Graston techniques. We'll talk about that in a little bit. Jonathan, you had a different question? Yep. So if my muscle fibers are designed to glide freely over one another, and some of them can't, that force is not going to be distributed wherever it needs. It's always going to be hung up in that area, which is going to create more and more stress around that area. And the more stress, because the forces aren't distributed evenly, then we're going to get more and more pain. They'll build up a metabolic waste, less blood supply in the area. Yeah, it's that cascade of events. Is that like, let's say, a knot? Most of the time when a patient says I have a knot, they're talking about trigger points, which is next. This feels like a generalized tightness with pain. So some of us might feel like, especially if you worked out, you say, oh, God, everything's tight, but it's tight with pain is typically the complaints about adhesions. And it's something that we can feel as our palpation techniques improve. We can feel adhesions. We can feel as we're palpating through muscles. We can say, okay, this tissue is freely moving. Oh, geez, this is not anymore. This is not KNOT, but NOT. This tissue is restricted in its mobility. So as our palpation skills improve, we can feel those. And as we palpate those, the patient will probably start talking about, oh yeah, that hurts. They'll vocalize it. So what transverse friction massage is breaking up adhesion. It's to break up the adhesion. It's going to allow the tendons to distribute those contractile stresses and forces, decreasing in pain perception. Although it's not comfortable as we apply it to our patient, hopefully we're getting to the goal of breaking up that adhesion so it doesn't hurt when that muscle is contracting or lengthening. So it's a repetitive, specific, non-gliding technique that produces movement between the fibers of the connective tissue. So no lubrication for this. We want plenty of friction because it's a non-gliding technique. It's a good way to put it. Yeah. 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 Again, my first option whenever the patient talks about massage, I say, I know exactly what you're asking for. This is, yeah. Yeah, we're on the same page here. Don't worry, I know what you want. So clinicians, fingers and patient skin move simultaneously to avoid skin injury. The friction must be provided perpendicular or transverse to the striations of the muscle tendons or fibers. So this is again applied anatomy. What direction of the fibers are they going? And our force is going to be perpendicular to those to try to break up those adhesions. When applying transverse friction massage to a tendon ligament, the tissue should be placed on a slight stretch. But if we're doing it to muscle belly, should be placed on slack. I don't have good reasons why that. Do you have why that? Why belly and slack, but tendons stretch? Belly. Yeah. Tendons. Okay, that's good thought. I would also put this in the category of guidance and not hard rule. You, as the patient's tissue is in your hands, feel free to, manipulate the tissue as you want. Some of these techniques you're probably going to need to put in maybe more of a stretch, maybe more of a slack. It's up to you, and the better your palpation skill develops, the more you'll be able to precisely dial in exactly how much length should we put that tissue under. So the point of contact, very specific, and palpation should occur to single out the exact area of tissue that's at fault, typically the most tender area. We're going to be using the second digit or the third digit. So this says second digit pointer finger for the small areas, third digit reinforcing the second digit. So that's this technique where our third digit's reinforcing our first. For people with really hyper flexible, hyper mobile fingers like me, I typically am using my other hand to reinforce my other fingers. So again, we have to figure out what works best for you and your mechanics. The depth of pressure should remain with the patient's pain tolerance, only deep enough to engage the tissue of interest and not beyond it. So relatively quick speed, 2 to 3 cycles per second, perform anywhere between 5 and 20 minutes, depending on the acuity of the injury. And really what we should start noticing some improved mobility of those tissues. So what it would be, can I borrow your forearm? Is that all right? So if palpate where you think those adhesions are, say, oh, that's it. The patient starts saying, hand position just because my fingers are so hypermobile. So I typically, if you're one of those people, then you might need to do that as well. The danger though is putting
Positioning, you know, John, I want to be seated. I saw you guys working sideline. I thought that was really cool. So something I said to Jonathan too was that it's easy for us to say, hey, try these on a piece of anatomy and do it. When you're a patient, when you do find that adhesion on your patient, you will then use your knowledge to put them in the best position for your body mechanics. So I would never say, oh, for me, always be in this position. For this, always be in that position. No, you have to figure out what's best for your body mechanics. You guys grabbed a stool to maintain your body mechanics. That was great too. I also think we had seen already with proper draping, even though most of the anatomy wasn't sensitive. I love seeing that extra thought, so that was really good. Trigger point deactivation. So trigger points are focus of hyper-irritability in a tissue that, when compressed, is locally tender, is sufficiently hypersensitive, gives rise to referred pain and tenderness. 70% of common trigger points looking at the set of non-acupressure points, so that's nice. You remember those? They're palpated nodule in a muscle tissue, skin, scars, ligaments, joint capsules, fascia. You can find one. It is obvious. It is. I think the nodule is a great way to describe it. They are classified as active or latent. It's always painful even without external pressure. Those are the ones that our patients are seeking out and that's telling us about. All of this in here have latent trigger points somewhere. Probably at our linear scap insertion to the scapula. That's probably where the most common ones are going to be, but there will be others. Probably glute med as well, especially if you're a runner. That's a good spot for that too. So do you know if you have, yeah, so we got TV, how you find this. So you have active trigger point right now. So this thing is going to be a little bit better for us to practice with, because without adhesions with healthy tissue, then it's tough to get really good at that transverse friction massage. Trigger point activation, we will definitely have some in here. So trigger point pressure release utilizations that uses the hands, electrical process, handheld tools, anything firm to apply pressure. Pressure is held for 20 to 60 seconds, when the sarcomeres to lengthen. The pressure should gradually increase to the point where the patient reports some level of discomfort. I like saying discomfort versus pain, but the patient should experience some. We need enough force for that. There's a picture of using that Alecanon for it. So, yeah, pressure here, we're going to hold it for 20 to 60 seconds. So using our anatomy, using our most obvious bony landmark that we can that fits their anatomy, keeps us safe, and using our body weight to apply that force and not muscling through it. So you don't want to hold a muscle through force for 60 seconds. Other interventions for trigger points include maybe some injections, dry needling, acupuncture, little spray and stretch potentially. That's maybe biofeedback would be another one. But we're going to try these trigger point release techniques. If you find one, you're going to hold the pressure there, enough pressure that it causes mild discomfort. You're going to say, okay, we're going to hold this here for a while. As we hold it, the sensation as you as a clinician feel, you should feel like it's kind of melting away. It should feel like a release. It should feel, firm to relax. And the patient will start to report that they're feeling less pressure. They'll say, oh, you're not putting as much pressure. No, my goal has been to put the same amount of pressure this entire time. It's getting better. So again, we're going to try to find the most obvious areas are, I think, the liver scap area is going to be for all of us. We're going to have some. Glute region, are probably going to be some, especially if you run on or other forms of exercise. If you know you have some, tell your clinician. I think this is a point where we need to focus on draping a little bit more. We also have, obviously, if these curtain rods don't fall down, we have these curtains. We also have the portable curtains there. So if you feel like you want to have a little bit more privacy, go ahead and do it. We've got everything, every tool available for you for that. But a little bit more focus on our draping probably as we get to the glute region. I'll let you guys make that call. Okay. All right. So let's practice finding some trigger points, definitely in the scapular region and definitely in the lateral hip region. Glute region is probably going to be some. Okay.
Are these muscle bellies? Like not the non-muscle belly?
Muscular junction, as the muscle is turning into the tendon, that's a common, as well as the muscle bellies. Yeah.
So it was, I could feel that it was moving out. Really saw. Would
Yeah.
that be a trigger point for you?
I have to palpate, probably not, but I have to palpate to know. Did you have a different question?
It can be done, it could be done.
Well, yes, it can. We always have to protect our patients. So if they're more comfortable wearing clothing, then that's fine. It increases the level of difficulty of palpation for the clinician. Because I'm getting feedback from their body, this is not just me applying something to their body. I'm using my hands as tool for feedback as well. So it makes it a little bit more difficult. It can happen, but especially as we're inexperienced with techniques, it might make it really hard, even a thin layer of clothing. So try it, and if it's great, great. If your patient's not comfortable with exposing tissue, great. I don't need to. If you're telling me I don't have to do a side, I'm fine with it. But it might be more difficult as you're less experienced with it. Okay. All right, anything else?
What is holding pressure?
Threshold pressure, so. If it was, Kiki's a scap, I would palpate and I would say like. So from here, so I found out exactly where, if you ever look like a genius, you just say, oh, is it hurt here? It always hurts there. So. Watch the patient in the waiting room filling out paperwork, and then as you're working with them, are you right-handed? Yeah. Are you not? Little David Copperfield. You guys know what David Copperfield is? No, magician. Chris Angel, let's see the.
Oh,
All right, enough magician talk. So, you find that trigger point, and then I'm gonna put a little pressure here. Yeah. How's that feeling to you? A little painful? All right, good. We're gonna hold this for about 20 to 60 seconds. Okay? And that's it. Now I'm using my thumb, I'm reinforcing my thumb underneath so I don't go into that hyperextension. The hyperextension of our digits are the big things that we want to prevent. So I'm here with that. So it's nice and straight. I could use this bony prominence. I don't love it for him. He's got a lot of muscle tissue. It's tough for me to do that. I could use my electron on there. What I should probably do is get him reinforced somewhere. So if he's like leaning on the table, maybe even with all of these pillows right over him, like something like that, it might be an option, but something along those lines that he doesn't have to actively like push back into before. So, but yeah, and then just holding this for 60 seconds. And eventually I'll start feeling that tissue. It'll feel like it's a little quivering at first, and then it'll just kind of melt away. Okay? All right, so go search for some, definitely going to be some in the scapular area, definitely some in the lateral hip area. If you know you got some more, talk to your clinician, okay? Next thing I want to talk about is myofascial release. Some techniques of it. So we're going to try to relieve the soft tissue from the abnormal grip of the tight fascia. Most commonly using myofascial spreads, myofascial mobilization. We're going to save some of that for a little bit later. Spread is pretty easy. In the side by side restriction, and then we're pulling apart on our hands. Tissues are spreading so resistance is felt. Once we feel that resistance, we're going to hold there. And at some point, that tissue will yield its resistance and we'll be able to spread our hands further apart. So it's similar sensation. Everyone with the trigger points felt those trigger points let go a little bit, felt it melt a little bit, right? So it's a similar sensation with this myofascial spread. So can I borrow you for this? So go ahead and go. So I put the feet on the bottom just for comfort. Okay, so go ahead and take off after if you can. So again, now, so let's make sure our patients are draped appropriately and can expose just whatever areas that I want. If you need an extra sheet for up top, then feel free to do that, especially if we're exposing more sensitive areas and for women as well. So with our myofascial spread is pretty easy. If you know where there's an area of resistance, all I'm gonna do is I'm gonna place my hands on either side and give a spread apart. See how that? I start feeling that resistance and then I just hold it. Most of the time, if I'm doing this, I like to cross my hands, that way I just lean with my body weight. See how that mechanism just spreads those hands apart, so that's oftentimes what I've tried to do. Hold it here, once that fascia starts to release, then I'll be able to spread my hands a little further apart. Now, fascia runs in every direction, so there is no one direction, it's not transverse from the massage where I have to know the fibers of the muscles, but then I'm able to measure that. We want our fascia to be flexible in every direction. So there are times I'm going to want to be over time to get more of this direction, maybe more diagonal, right? So you just have to figure out where is the restriction, what do I want to, what directions I want to move it. So yeah, there's rare exceptions. I don't cross my arms for this. What I want to do is lean with my body weight next. It's just gonna spread my. If I have to be here, I have to provide that force. It's not quite as friendly to my body mechanics. So mess around with it. Let's see what you feel like, you know. In every single direction, see where your mechanics are, and then say, geez, I think this is a little restricted. Let me go this way. Spread until you feel the resistance. As it loosens up, I'll just be able to spread my hand out a little bit. That's all.
Is the body allowing to spread your hands out or are you moving your hands?
That's like we felt with the trigger point where you felt like it's dissipated. You will feel it under your hands. You say like, okay, this is now that resistance is less. So again, it's a reciprocal. His body's giving me feedback and I'm adjusting to what his body's telling me. It's reciprocal.
Would it be more beneficial or as to like a starting point of something more like vague? Like they don't know exactly where it is, like more pointed afterwards sort of thing?
Potentially, yeah.
This is like a larger surface area.
Yeah.
Okay.
Sure, why not? Fascia's everywhere. Yeah.
It's already numbered.
I don't have the exact prescription for that, yeah. Yep. I'm not doing it for more than 5 minutes. But, you know. We're 30 seconds. I can't believe it's going bad. Yeah, but you guys are kind of your patients and I.
So it's really fun.
Sure, if you need more sheets or towels, please help yourself, especially for women, you know, you've got more there. Let's try that out. So, just some classic massage techniques. Got just a few examples of each. So classic massage, improving function in 10 weeks for patients with chronic low back pain. Boy, that's nice. Chronic low back pain, 10 weeks. Yeah, that's pretty good. Reduce edema, potentially exercise induced for onset muscle soreness. So potentially that's good. We're going to start with pet massage. Pet massage, we want as little lubricant as possible. When you use Equinox, that's where we're going to use the most. We want the most amount of gliding. But for petricide, we want only some. So we want minimalist. Petricide, we're going to be brushing the skin and otherwise tissue from its normal state, pressing, rolling, squeezing, kneading, and then releasing it. This is a deeper than so I think we do like the deepest for the tissue first. And then we're kind of going a little bit medium, and then when we get to FRS, it will be the most superficial. So we have muscle and fascia, improving circulation, cellular nutrition, can potentially break up adhesions and provide an elongation effect. In fact, this skin rolling technique is one of its modified mobilization as well. So we have 3 techniques: basic two-handed, circular two-handed, and skin rolling. Basic two-handed, you put your hands in the shape of a little hand guy here. And then you just go wah. That's all you do. Yeah, I have to make the sound or else. Yeah, it doesn't else. Mostly not there doing it that way. Yeah. Circular two-handed, hands. Moving circular directions, almost with the karate kid. I guess a Cobra Kai or wax on, right? So we could do that. And then skin, this will be your favorite because you're tied to the ocean. So we're going to pick up this skin and we're going to roll it underneath of our hands. So, would you mind if we? So I'm going to try and do this with no lubrication initially. It feels like I'm pinching his skin and all, but I need to apply some. But again, I want as little as possible. So first the packing. So my two-handed technique is I'm just going to be, I want to say gathering the tissue. I don't want to say pinching, right? Because that would be on. So I'm taking my whole hands and making my little Pac-Man guy, or Mrs. Pac-Man if you want to be more inclusive. And gathering the tissue, pulling away from his body, and then I'm immediately releasing. And as I'm releasing, the other hand comes in and does the same thing. We can travel with this. So I think we've been fairly stationary with our techniques before, but now we get to start traveling with it, where we get to, you know, I could go more lateral, I could go medial, I could go cephalothoracic, like I can move with that. And it's just gonna be nice rhythm, you know, nice and slow. This is probably just a little bit too fast. Does it feel like I'm pinching or pulling at all? It feels all right. So yeah, that's it. Basic.
With all that extra skin.
Yeah, yeah. More restriction, you can just focus your effort right there. So there's our basic two-handed. Our circular is two-handed circular, so one is gonna go clockwise, the other is gonna go counterclockwise. You can see the skin is holding up right there. I can go the other direction if I want to. Show that to you, thank you. Okay, so basic two-handed, one hand's going one direction, the other goes the other, and then we got a little bit of tissue building up right here. And then the skin rolling technique, so now I'm gathering the skin and I'm pushing my thumbs forward to create that kind of weight. This one, yeah, I feel like I need just a little bit of lubricant. What do you think, Kyle, with this one, just because of the way my thumbs have to glide? Yeah. Um, but that's the technique. Yeah. Well, it's mostly fishing. Gathering the skin. Stay like how I gather. I'm just pushing my thumbs forward to create that wave type effect on them. Okay, and that's the one you probably need a little bit of movement. If you put too much, you won't be able to gather. It'll just keep sliding out of your hand. So you want just a little. Okay. All right. For the video, you can see classic two-handed Pac-Man grip. You're gonna gather the skin, pull it together, and release, and as I release one hand, the other hand. That's it.
Let's have it down, don't forget.
Yeah, it was.
The next up, hear you.
Okay.
Like, do you recommend like lotion or like ultrasound gel, like what are?
Free, that's what we're gonna use. Each clinic has whatever, you've got a big tub of a 5 gallon bucket somewhere that you use, yeah. Both, you know,
Well, I wasn't answering that question. Because then there's a lot of allergies, especially if the lotion contains beeswax. If somebody is allergic to bees and you're using something like beeswax, that's really good. And check in to see what they have, and then, in the classroom, you don't put everything is into the container, I gave you sticks. And then you can start with it on your hands, sometimes I use it to warm my hands.
yeah, yeah.
And hold this other hands coming out.
So again, be really careful. The first two circular and the two-handed, you might only need just a little bit. The skin will only need a little bit more, but if you do put on too much, their skin's gonna just slide out and you're not gonna get it. Okay, so we should be able to lift this tissue away from their body. That's the goal for the petrissage. Okay.
In the body, like big or small, it works better, what of the techniques, or just kind of play around with it?
Play around with it.
Oh.
Yeah. All right, let's that's the episode. So. Right. The 5 seconds, so we'll be wanting. Head strokes, sliding and gliding the hands over the body. So now with a lot more lubricant. Typically, it's the same direction as the products. Well, and for really superficial, deep the same direction as the muscle fibers. But slow speed, palms, fingers, thumbs, knuckles, forearms. Whatever works for them. So the 3 examples we have are shingles, bilateral tree, and horizontal stroking. So, did your mind here? So singles are pretty easy. All I'm gonna do is I'm gonna have one hand start to slide up and the other hand comes in right behind it to replace it. Even a little too heavy with my pressure there. So again, it should be nice and light. The amount of pressure you put, if I wanted to do more lymphatic flow, it would be really, really superficial. You shouldn't be seeing much skin moving at all. It's extremely light. If I wanted to do more of the muscle, then I can go a little bit deeper than that. But that's all it is. And if I do it right, patient feels almost like one continuous hand if I do it right. Like a treadmill. Sure.
And then
What was the analogy you had for, you had something? Oh, myofascial spread, you said like the beginning stages of fracture, right?
before tracking, you could track what now really good stages for.
That's a good idea. So, all right, so we got our treadmill on this one, right, shingles, so yeah, nice and slow. Nice and superficial. All right. A bilateral tree. Starting our hands up this way. Hands are coming out and then they spread apart.
Is that always going down? Perfect.
No, I don't think so. I think I can do bilateral tree anyway. It just has to make sense for what you want. All right, so there's our bilateral tree. Horizontal stroking, pretty easy. So we're here to here.
Do we know when we want to go with the muscle fiber and against it?
Your decision making. I find the tricky thing with the horizontal one is not getting that tissue tension. So different than the tetrasage where we want it to be lifting and pulling everything off. For this, it's so light and superficial. I shouldn't be seeing that skin puckering up. That's the tricky thing. Okay. All right, any questions on that? So just talk about Toponin next as well. Percussion movements, rapid alternating manner, minimum force is required and the wrists should be relaxed. So. Most frequently that I use it for is to increase muscle tone. So we talked a little bit before, I talked with Ron a little bit about this, in this case, I'll show the hamstring. This hamstring needs a contraction, if I need more out of it, I can do the Pultman type techniques to add that proprioceptive input. That's the most common that I do. Some of these techniques, especially one of them, can be really good for respiratory therapy. So when we get into, when we talk about cystic fibrosis and pathology, when we had to, mobilize the airway, we have vibration percussion techniques. That's the other category that I use these most often. So those are the two reasons I would use this for. I don't see a lot of other reasons to use them outside of those two. Do you have any that you like to use to form it?
And the treatment, like just.
Your ties together. Sorry about that. I must do like your face. All right, so everything in company, so, really flexible wrists. We want to be really soft. As I make contact with my patient, it should basically, my wrist should bounce off of my patient. I'm not rigid. Okay, and that is the thing that we really want to practice for all of these techniques. So, hacking. Right. Other, wrapping. Same thing, and again, those ribs have to be like really mobile. If they're stiff at all, then it's not gonna work. And then the company technique, again, we're gonna make little domes with our hands. Well, so the company that's the number that I use for hand weight clearance. You do after drainage, and then you do some cupping techniques, and it really does mobilize those, whatever junk is in the lung. So that's what I use it the most. Wrapping for muscle tone, probably goes at the end of the treatment. Right, any questions on those 6 techniques? So, from my experience, there's a that require the most amount of practice, because it's really tough to keep our wrists in a nice flexible manner. I think about. Okay, I'm going to finish up with the lecture, and then we'll be done. Scar massage. The scars can be really thick and glued down. So there's one particular scar massage technique. Everything to mobilize the scar tissue so that it doesn't adhere deeply, and that it can provide flexibility. So anything lifting, budding, shear forces, break up adhesions, transverse massage, myofascial spread, myofascial mobilizations, petricide, anything you can do in all different directions too. So regardless to achieve normal range of motion. We talked briefly earlier about instrument assisted soft tissue mobilization. The other common way to describe that would be Graston techniques. That's the kind of more brand name. So based on theory of connective tissue remodeling and initiation of inflammatory response, we have to clearly communicate what the goal is to the patient. We are starting an inflammation response. We will likely see arrhythmia afterwards. Maybe some superficial bruising after as well. Short duration, approximately 5 minutes. So, man, this is the best one for me. Then also, here's some examples of some of those tools that we get to use.
Is it called grafting?
Yeah, Stin.
Oh, graft.
Yeah. Yep. One of the great scams in all of, at least, definitely physical therapy. There's a lot of different aspects of medicine that do it. If you want to make a bunch of money and you just give something your name, change the verbiage around it, and then take an old technique, change the verbiage around and give it your name, and then sell a bunch of courses and say, no, now you're Graston certified. Wait, is that different than instrument aided? Oh, yeah, it definitely is, because it says my name on it. So you got to pay me for that. So here's some other massage types that you might come across. The standard technique focused on posture and kinesthetic awareness. Connective tissue massage, system of connective tissue massage that are thought to affect the vascular and visceral reflexes. Cranial sacral, moving the sutures of the cranium in a rhythmic motion to restore cerebral spinal fluid rhythm and circulation. Helix developed the transverse friction massage. Bendel-Crass is system of passive movement re-education. Manual lymph drainage, we did talk about in first semester. Neuromuscular therapy, more of the trigger point. Riveting, the approach to myofascial manipulation done in a series of 10 1-hour sessions. So here's where I'm always skeptical, right? So again, do I know everything? Almost like 99%. I'm working on it. But here's my skepticism coming in. I don't know if it's going to take 1 hour, 10 1-hour sessions. It might not take 8 or 12 or 4. Well, because I want you to pay for 10 and we're going to do 10. That's why. All right, well, that's what you're the model. So yeah, my skeptical immediately goes up. Doesn't mean it's not working. I'm just very skeptical of it. And then the Traeger approach, oscillatory tissue mobilization, similar to stuff we've done earlier. Sports massage, another one. One of the traditional Western massage, part of the full body circulation and range of motion. So lastly, to document what area do we do, what specific treatment, what specific technique do we use, length of time, purpose for chosen technique in relation to the goals, and then patient response, including integrity of the skin, are all things we'd like to document. All right, any questions on that stuff?
There are maybe reason between Topman and. How do you say it?
Aplarage?
Is there like one you choose over the other? Are they like?
No, I don't do a lot of Topman. Topman is nothing as light, superficial, feels good, good for blood flow, very relaxing. I don't think I get quite the same effects of relaxation for our patients for that. Again, the Topman category that I use for is, all I use it for is to increase tone of muscles that are sleepy and, you know, my choices are, you know, some hacking and wrapping techniques versus Russian or biofeedback. Like that's, I'm going to be slapping that muscle as, yeah, basically I'm increasing proprioceptive input to try to get the motor output. And then for me, it's to mobilize in the lung. Those are the categories that I use it for. What do you got, Tony?
A lot of times I hold temporary for one.
Yeah.
The tissue to let you in for the rest.
That's a great way to think of it. If I have to do, especially a more aggressive technique, the aplarage is a great way to warm up the tissue, get the patient to relax so that I can do some of the more aggressive techniques. That's a great idea.
For that, we need to bring the patient on, and then the fact, like, that like the patient responded well to the treatment, like how, do you have an example of like,
I never say patient responded well.
no, I'm saying you made that,
Yeah.
because of course they shouldn't, but like from a side, like.
Does everybody, if you do that, then you did a good job. If you read any notes and your clinical instructors will write these notes and you can have them email me. Whenever we say, here's the lazy therapist documentation. Patient responded well, continue with physical therapy, right? That's the plan, is continue with physical therapy. And then the assessment is patient responded well. All right, the patient should always respond well. What does it mean not to respond well? It means I screwed something up, right? Yeah, you know, we want to do these squats, we put a bar on their back and they don't respond anymore. They didn't respond well to that. Like they, you know, the patient should always respond well. The patient's response, the patient enjoy it or not? If they didn't enjoy it, bring them off the hook for next time. When it's a patient response, not emotional response, it's, did the tissue do what I asked it to? Do we have less of we found a trigger point, we did trigger point at least, do we have less of a trigger point? So I'm asking for the tissue response. And then just because you got me on it. Our plan, continue with physical therapy. Yes, of course, that's the plan. Yes, unless we've achieved our goals and patient discharge, that's the plan. I know that's the plan. You didn't give me any additional information. The additional information I'm asking for is, what are you going to change for next time? What do you anticipate changing? Changing sets, changing weights, changing color TheraBand, adding a new technique, adding, tell me what you want to do. Just tell me what you think you're going to do, because you just worked with that patient for 30 to 60 minutes. Nobody knows more about that patient than you. Tell me what you think next time is going to be like. That way, when you call out, I know what to do. And then with your information, I can talk to the patient and say, okay, that plan, we can execute it. Or the patient says, no, but I sprained my ankle. Great, so we don't have to do that other thing. Save for the next time, right? So just saying patient responded well, continue with physical therapy, garbage note. Tell your CIs I said so. All right, anything else? So you've got some